I'm Rob Peters from GE Healthcare, and I'd like to thank you for joining this webinar. GE is proud to continue our sponsorship of the ASNR to help foster clinical education and technical development of neuroimaging. In today's webinar, you'll hear about our pioneering deep learning-based reconstruction called AIR Recon DL, which has now been installed at over 150 systems across the globe. My colleague Suchi Banerjee will share some of the latest developments in neuroimaging at GE, and our guest presenter, Dr. Aaron Field from University of Wisconsin-Madison, will then share some of his team's experience using AIR Recon DL in their clinical neuroradiology practice, with a focus on exam time reduction and some great examples in high-resolution cortical epilepsy cases. In 2019, we introduced our new AIR family of technologies, which includes our award-winning AIR coils and solutions for workflow and image quality. With our most recent software release, the SignaWorks AIR IQ Edition, I'm glad to report that we've extended these capabilities, and they are now available on both 1.5T and 3T and compatible with upgrade for the vast majority of our installed base systems. AirX Brain is our deep learning-based tool for intelligent slice placement. Built on a diverse training set of over 36,000 images, AirX automatically places your slices in a very consistent and accurate manner, leading to productivity and up to 5-fold reduction in setup time with 4 times fewer interactions with the MR console. You can imagine the benefit of having consistent and reproducible scan planes when conducting longitudinal exams on the same patient. With AirX, you have reproducible scan planes that are independent of patient positioning and MR technologist. Quite possibly, you've heard about our new deep learning-based reconstruction called AIR Recon DL. It will really change the way you think of MR as it challenges the historical trade-off of SNR, scan time, and resolution, leading to significantly shorter exam times with equal or better image quality. AIR Recon DL is best appreciated when comparing images with conventional reconstruction, as shown in red. Here we see considerably reduced noise and sharper detail with AIR Recon DL from the same raw data. When used within a routine neuro exam, AIR Recon DL can lead to shorter exam times, as demonstrated in this example, comprising 5 different scans, all in under 4 minutes. And I'm happy to report that in our latest software release, we've extended AIR Recon DL to diffusion-weighted EPI. In this same software release, we've extended HyperSense, our industry-first compressed sensing acceleration solution, to several additional sequences such as T1-weighted MP-RAGE and Bravo. Here are some examples with MP-RAGE showing how HyperSense can be used for scan time reduction, as shown in the middle, or for higher resolution, as shown on the right. Lastly, we have Osteo, our novel MR bone imaging technique based on 0TE sequence. With Osteo, you can visualize and 3D render the skull and spine to complement your MR soft tissue exam. Think of the possibilities of including this new sequence with your neuro protocols. I'd like to leave you with a quick glimpse of our new Signa 7T system, which is now FDA cleared to join our extensive portfolio of Signa MR systems. As our 3rd generation 7T, Signa 7T has evolved with components from the former Discovery MR950 7T, our Signa Premier 3T, and a newly designed Ultra G gradient coil, the most powerful whole body gradient in the industry. With such strong and powerful gradients, Signa 7T can enable sub-millimeter diffusion tensor imaging, as shown in this example, of track density and fractional anisotropy. With exceptional stability, both motor and resting state fMRI show the resolution, SNR, and sensitivity that you would expect from a 7T system, which we envision to be a key tool in scientific discovery and clinical translation. Finally, I would like to leave you with a brief look at what happens when we combine our most powerful system with our deep learning-based reconstruction. Imagine the possibilities of Cygnus 7T with AIR Recon DL, a combination that is now pending with the US FDA. And with that, I'm happy to hand it off to my colleague Suchi Banerjee to share some GE development insights in neuroimaging.
Thank you, Rob, for the introduction. So let me give all of you a little bit more insight into our development vision. This is a very high-level, broad overview of our neuro product portfolio, categorized into speed-up tools and fast, where we have the usual tools for reduced field of view imaging or hypercube, compressed sensing, which is called hypersense, simultaneous multi-slice or hyperband. And you heard from Rob about the exciting new addition of AIR Recon DL, which can simultaneously improve imaging speed and image quality. On the consistency side, you heard about AIRX, the deep learning-based landmark identification for consistent slice prescription. Here I have some examples also for consistency to motion with 3D Promo, our navigator-based prospective motion correction that is now extended beyond the cube family of sequences such as cube DIR, FLAIR, and T2 to the 3D T1s like MPRage and Promo. Here we are showing a few examples of consistent diffusion for minimally distorted diffusion imaging with tools such as Focus for reduced field of view imaging, Muse, which is our segmented multi-shot API, Progress for top-up like distortion correction, and here there is an example of two-point Dixon method for fail-proof fat suppression. On the quantifiable personalized side aspect, MAGIC is our synthetic MR approach for getting 9 different contrasts from a single 2D scan, and then one can also retrospectively change scan parameters such as echo time, TR, and inversion time to get the desired image contrast for every single subject. Our goal is to go towards injection-free, noise-free imaging by boosting our non-contrast perfusion portfolio. Here are some examples of also complete vascular assessment with 4D flow, with vessel wall imaging, and then our silence suite, which consists of time of flight, T1, T2, and PD sequences. Our end goal is not just to keep on adding tools to a cluttered tool chest, but to have an end-to-end neuroimaging workflow, which starts with a standardized patient-centric workflow with a patient-adaptive coil, consistent slice positioning, then having an extensive brain imaging application suite with fast, motion-robust, high-resolution imaging, consistent diffusion, robust quantitative evaluation of brain microstructures, function, and metabolites, and then having a complete, comprehensive library of analysis tools that can glean as much information as possible from these images so that one can have differential diagnosis, personalized and precise treatment planning and therapy monitoring, and more in the future to be able to integrate multimodal imaging, proteomics, genomics to the imaging data, all built on a foundation of artificial intelligence. Let me give a couple of examples of how everything can come together for particular clinical applications. Here is an example of multiple sclerosis, where subjects come back for repeat scans for longitudinal monitoring, where AIRX can help in consistent slice prescription, no matter how the subject is positioned within the coil. On the scan side, as you can see, very subtle white matter lesions that might not be as obvious in a 2D scan like T2 FLAIR can be much better visualized in 3D isotropic imaging like Promo with Cube FLAIR, Cube DIR, and you can see that in the zoomed inset as well. Fast, high-resolution, isotropic T2 star imaging with 3D EPI can give more specificity to the white matter hyperintensity lesions by having the central vein sign. On the analysis side, we have quant-IB for looking at the gross volumetry, the atrophy, as well as we have tools for longitudinal monitoring of the lesions. Here you see some of the color coding of the new, consistent, and disappearing lesions, and also the total lesion count and loads. We are also adding myelin mapping from synthetic MR, which can be extracted from the MAGIC scans so that one can have longitudinal monitoring of myelination as well during therapy monitoring. Here is another example in the context of neurodegenerative diseases. I hope that gives you an idea of where we are trying to go by having an end-to-end neuroimaging workflow. I want to give you a little sneak peek of some of the AIR Recon DL developments that we are doing. Rob gave a nice overview of what we have already in product. So the human connectome imaging has now become much more mainstream in clinical brain imaging because now it's possible to do whole brain multi-shell DTI in a much faster scan time. Now, as you heard, that it has our AIR Recon DL product offering has now been extended to diffusion as well. We are looking at it for DTI, for tractography, where, as you know, for high B values, such as B equal to 3000 on the 3T, the images can be quite SNR starved. And here is an example of the human connectome protocol on our Cigna Premier, where the color FA maps for B equal to 3000, as you would expect, are SNR starved. We found considerable significant SNR improvement when we apply AIR Recon DL to the MR data. And these changes, this improvement in SNR was much more significant than we would see for very standard tools that are applied to just the Q-space denoising. And here I'm showing just a more zoomed inset in one of the slice locations. Here is another example of our development directions. This is in 3D T1, which is an essential component of most brain routine exams. And here you can see the AIR Recon DL reconstructions of the same data. The MP-RAGE data provides much better SNR and image sharpness. As Rob mentioned, combining the deep learning technology with the higher sensitivity of 7T can provide stellar results. Here you can see some of the stellar details that can be observed in the T2 star GRE that's reconstructed by AIR Recon DL in the anterior commissure and in the lines of Gennari. So when we started doing this, the technical developments for this, for AIR Recon DL, some of the questions that we looked at were very similar to when parallel imaging was being developed. You know, are the image details being preserved? Are the clinical, are pathologies being visualized correctly? Are all the image structures preserved? And so while our scientists did all the rigorous technical validations, they did their testing on phantoms and digital reference objects. Very early on, we partnered with our clinical collaborators around the world to see that the integrity of the images is maintained, and in many cases, the lesion conspicuity is perhaps improved with AIR Recon DL. We have had many abstracts at RSNA, at ASSR, at ISMRM, but I would like to highlight 3 peer-reviewed journal publications that have come out. One on thin slice pituitary MRI with this technique from Asan Medical Center in Korea. One on improvement of late gadolinium enhancement image quality in looking at myocardial scar quantification that came out from Erasmus, and novel deep and this technique for looking at prostate imaging that came out from MD Anderson Cancer Center. Today it's my pleasure to have with us Dr. Aaron Field, from University of Wisconsin-Madison, who will share his early experiences of using this technique for neuroimaging. So over to you, Dr. Fields.
All right, thank you, Sushi. It's my pleasure to share with you all the early experience with AIR Recon DL at the University of Wisconsin in Madison, incorporating it into our neuroimaging protocols. I'd like to start by acknowledging a few colleagues. First and foremost, Greg Avey, who conducted a formal evaluation of Recon DL, the results of which I will share with you. And then Justin Brucker and Megan Vadnais, who just shared with me some examples that they collected more informally, which I will also share with you. So we asked the question that I think a lot of you probably are asking, which is how do we incorporate AIR Recon DL into our MR protocols? You know, we've already seen that Recon DL can boost SNR and boost spatial resolution, which of course we're always trading off with each other, and we're trading them both off with speed. And so where does AIR Recon DL fit into all of these trade-offs that we make in our MR protocols? Well, for starters, you can just add AIR Recon DL to an existing MR protocol for an SNR boost. And that's what we're seeing here. So this is just conventional Fourier transform reconstruction on the left and Recon DL on the right. And you can see the improved SNR that you get just by adding this reconstruction to an existing protocol. And here's a magnified view of that. And you can see, for example, those perivascular spaces in the white matter are much more clearly visible with their Recon DL thanks to the SNR boost. And in this slide shared with me by GE, you can see that this is a user selectable SNR improvement. So you can use low, medium, or high settings on the AIR Recon DL for increasing levels of SNR boost. Now we asked the question, if instead of just adding AIR Recon DL to an existing protocol, what if we accelerated our protocols? Could we use AIR Recon DL to recover the SNR lost to the acceleration? So what we did was start with just some baseline T1 and T2 image acquisitions with the conventional Fourier transform reconstruction, and then accelerated those by at least 50%. Using different approaches. So we decreased the NEX, we decreased the in-plane resolution, in other words, the matrix. We used increasing levels of parallel imaging factors. And then we compared the Recon DL to conventional Fourier transform reconstruction. And we did this in 10 volunteers on a Discovery MR750, which is a 3T scanner using a 32-channel head coil. And then we showed the images side by side to 3 blinded neuroradiologists and asked them to provide Likert scores for SNR and perceived resolution and overall image quality. So here's just one example. This was with fairly aggressive acceleration, a parallel imaging factor of 4, which was a 78% speed up factor. And on the left, you can see that we take a significant SNR hit using the conventional Fourier transform reconstruction, and you can see how nicely the Recon DL recovers that lost SNR on the image on the right. So here are the various ways that we accelerated our baseline sequence, which clocks in at 2 minutes, 24 seconds. And we aimed for a 50% or more acceleration. So we used 3 different parallel imaging factors, 2, 3, and 4. We decreased the NEX from 2 to 1. We reduced the matrix. And so that's 5 different approaches to accelerating our baseline sequence. And here's our results. So first of all, in general, T2-weighted images were generally more amenable to recovering lost image quality than the T1 series. And we think that has a lot to do with the image contrast. And so that's something that we did conclude from this, is that the benefits are a function of the image contrast that you have to begin with. So for T2 weighted images, the perceived SNR was superior in all cases, regardless of how we did the acceleration. The perceived SNR was superior with the Recon DL compared to conventional Fourier reconstruction. For T1 weighted images, it was at least non-inferior. Same for perceived resolution. That was superior across the board for all methods of acceleration for T2 weighted images. For T1, it was at least non-inferior, with just one exception, the reduced matrix T1 weighted images, where it was actually just slightly detrimental. The perceived SNR gain in general was more significant than the perceived resolution improvements. And for overall image quality, again, T2 weighted imaging was definitely it was more beneficial to T2 weighted imaging, where the Recon DL was superior for all methods of acceleration except the most aggressive parallel imaging acceleration. Otherwise, image quality overall was superior for T2. For T1, it was at least non-inferior for a modest acceleration parallel imaging factors of 2 or 3. We did see some artifacts that were accentuated by the algorithm, primarily on T1, only on one of the 5 acceleration methods for T2, the most aggressive parallel imaging acceleration. We think what's happening here is that the algorithm is reducing noise without blurring fine structural details, which of course is exactly what you want. But occasionally an artifact can be accentuated because of course the algorithm doesn't know an artifact from an important structural detail. And so I'll show you a few examples of that. So here are some examples that we acquired just outside this formal evaluation. In some cases, we accelerated our conventional series. In other cases, we just added the Recon DL to our existing protocol. This is brachial plexus, T1 FSC. On the screen left, you can see that's our standard sequence, which clocks in at 4 minutes, 15 seconds. In the center, you can see the SNR hit that you take with a fairly aggressive acceleration. So we reduced that scan time to just under a minute with a parallel imaging factor of 4 with the SNR hit that you would expect. And then you can see how nicely that lost SNR was recovered by the Recon DL on screen right. Here's a lumbar spine, T2. No acceleration here. We just added the Recon DL to our conventional protocol, and you can see the SNR boost that you get from the Recon DL, which facilitates identification of fine details. Same for this lumbosacral plexus, no acceleration, just adding Recon DL, looking at the fine detail of the lumbosacral plexus is definitely aided by the SNR boost. Same for stir imaging in the lumbosacral plexus. And now I'd like to show you some examples where we use Recon DL in our pediatric epilepsy protocols. So as you know, we're always trying to scan faster in children, reducing levels of sedation, reducing motion on unsedated children. And so we're very interested in using Recon DL for accelerating pediatric protocols. On the top, you see our original baseline protocol. On the bottom, Recon DL with the high setting. And you can see, for example, in the hippocampal formations, the SNR boost that you get from Recon DL really facilitates assessing that fine detail. With epilepsy, you know, we're always looking for fairly subtle structural details, structural abnormalities, cortical dysplasias, gray matter heterotopias, those sorts of things that can be extremely difficult to see. We always like smaller voxels for those things if possible. Here we cut the slice thickness from 2.5 to 1.5. You can see the SNR hit that you take on the original Fourier transform reconstruction, and how nicely the Recon DL recovers that lost SNR on the bottom. Here we just added Recon DL to an existing protocol with no other changes. This was a patient with some perisylvian polymicrogyria and subependymal gray matter heterotopia. Again, we're always looking for very subtle structural details on these epilepsy exams, and you can see how nicely the SNR boost shows you those fine details. This was a patient with polymicrogyria at the depths of the right superior frontal sulcus, and the SNR boost you get from Recon DL makes that just a little bit more conspicuous. We need all the help that we can get on these epilepsy exams. Sometimes they're extremely subtle. Here was a focal cortical dysplasia in the right superior frontal gyrus, and you have some very subtle, as you often do, very subtle white matter abnormalities subjacent to the dysplastic cortex, radiating towards the margin of the ventricle along the radial glial fibers. And it's very easy to overlook this, especially when you have limited SNR. And so on the bottom, I think you can see very nicely how much more conspicuous that very subtle gliotic change in the white matter is. This was another patient with a focal cortical dysplasia in the coronal plane, looking at the anterior temporal lobes. There's some diminished there's diminished white matter volume and subtle cortical gray matter thickening in the left temporal lobe, with the SNR boost much more readily identified. This was another example of a focal cortical dysplasia in the right temporal pole with, again, very nice SNR boost, making those fine details more clear. Now, I'll show you now a few examples of the artifacts I mentioned. So these seem to be often phase artifacts or motion artifacts that get accentuated by the Recon DL. We're able to read through these, of course. We recognize them for what they are, but they can occasionally be a little bit accentuated. Here's an example of a little bit of ringing in the genu of the corpus callosum. It's barely perceptible on the Fourier transform reconstruction, and it just gets accentuated just a little bit by the Recon DL. So to conclude, AIR Recon DL can improve the perceived SNR of existing protocols, but it can also substantially mitigate lost SNR and lost image quality with accelerations of 50% or more. And so that's where we've been focusing our attention, trying to incorporate this into faster and faster protocols. We're doing more MR scanning out of the ER. We're constantly in search of faster approaches to things, and so the Recon DL is really coming in handy for us. The benefits do depend on what strategy you use for the acceleration and what image contrast you're talking about. We've only formally looked at T1 and T2, but of course it can be used with T2 flare, T2 star, and so on. And so I encourage you all to experiment with Recon DL and see where you can accelerate your protocols and find something that works for you. It has user selectable strength settings, so if you use it on high and you find that maybe the image looks a little bit too processed, you can back off on it. Keep an eye out for occasional artifacts that are accentuated just a little bit in some cases. And I know that GE is continuing to work on this, and the reconstruction, I'm sure, will continue to evolve. And so that's all I have for you. I thank you so much for your attention, and I hope that you enjoy the rest of the virtual ASNR 2021.
But we'd like to thank you for joining us today, and we're grateful to Dr. Field for sharing his team's impressions of AIR Recon DL. If you'd like to learn more, please connect with us at the GE virtual booth at ASNR or connect with your local GE representative. We'd love to hear from you.